Hoy tenemos el privilegio de contar con 3 expertos internacionales, líderes mundiales en el tema de amiloidosis cardíaca y expertos a nivel local, para llevar a cabo esta actividad esponsoreada por Pfizer, que tiene como finalidad conocer mejor un poco lo que es el diagnóstico de la amiloidosis cardíaca, no solo en su parte diagnóstica, como también en su tratamiento. Yo voy a moderar esta mesa junto con un expresidente de la Federación Argentina de Cardiología, el doctor Jorge Camilletti. Jorge va a moderar esta mesa. La idea, un poco la mecánica, vamos a tener 3 conferencias, que la idea van a ser conferencias lo más prácticas posibles en diferentes temas, abarcando prácticamente la totalidad de la amiloidosis cardíaca. Y posteriormente a esto, junto con el panel de expertos locales, vamos a hacer aproximadamente 15 minutos de preguntas para generar cierta discusión con los invitados, con los disertantes. Jorge, te paso la palabra.
Bueno, gracias, Carlos. Bueno, dentro de las cosas a tener en cuenta, los asistentes pueden tener traducciones simultáneas. Si van al mundito que tenemos abajo en la línea inferior, le podemos dar clic y ahí cliqueamos español y podemos tener la traducción simultánea. Carlos, si te parece, comenzamos con las disertaciones. Me gustaría que presentes a la primera disertante.
Bien. Bueno, la primera conferencia la va a dar la doctora Marianna Fontana, quien realmente es muy conocida en el campo de la resonancia cardíaca y de la amiloidosis cardíaca en particular. Marianna está encargada, es directora del departamento de resonancia del Royal Free Hospital, es profesora de cardiología en ese mismo hospital y se encarga un poco, está dirigiendo el Centro Nacional de Amiloidosis que se encuentra en Londres. Realmente es un privilegio contar con Marianna, tiene un sinnúmero de publicaciones en este tema. Marianna va a hablar de la utilidad de la multimodalidad de imagen en la amiloidosis cardíaca y cuál es el algoritmo diagnóstico para arribar a un diagnóstico preciso. Muchas gracias, Marianna.
Thank you very much for this invitation to speak. It's a pleasure for me to be here today. So in the next 15 minutes, I'll briefly talk about multimodality imaging in cardiac amiloidosis, so which is the diagnostic path. This is my disclosure. So what do we want from an imaging technique when we think about amyloidosis? These are all the steps that we need to do to basically develop a new imaging technique or a new imaging biomarker. So we start from being able to detect health and disease. We want to be able to do that with a high diagnostic accuracy, so sensitivity and specificity. Then we need to demonstrate that our biomarker or imaging technique can stratify prognosis, can track changes over time. But what we need to bear in mind that is what we really want is to be able to follow treatment response and guide treatment strategy. And by doing so, being able with our imaging to actually impact on prognosis. So I will go through all these different steps and I will show you where we are with multimodality imaging in cardiac amyloidosis. So let's start from a diagnosis. So echocardiography is the first imaging modality that we all do in patients who present with heart failure. And what we typically see is concentric hypertrophy, which is very commonly asymmetric. We see atrial dilatation. We typically describe these patients as a preserved left ventricular ejection fraction, but significantly reduced longitudinal function. So actually, describing this patient just with preserved left ventricular ejection fraction is not really a good way to describe the systolic function in these patients. In terms of diastole, they often have a restricting filling pattern, but they also do present with just only impaired relaxation. So early pattern of diastolic dysfunction should exclude cardiac amyloidosis. Then pleural and pericardial effusion are very common, but this is more in AL rather than ATTR. Adding strain examination, more specifically longitudinal strain, definitely help to add specificity to the echocardiographic examination. And what we get here typically is reduction in the basal and mid segment or in the longitudinal strain with preserved longitudinal strain only in the apical segment. And this gives the typical bullseye appearance on the polar plot map here, where you see that when here we represent each segment as a line, only the apical segment reach a good negative peak velocity, And here on the polar plot map, only the apical segment have got the red. So normal velocities again in the longitudinal strain. But so what we can do with echocardiography is that we can assess structural and functional features to then stratify the probability of presence or absence of cardiac amyloidosis as very unlikely or very likely, or there's a wide range of intermediate results. But what we really can't do, we can't, after just an echocardiographic examination, point the finger and say, this patient definitely has got cardiac amyloidosis. So two imaging modalities have really transformed the non-invasive pathway to the diagnosis of cardiac amyloidosis. And these one are cardiac MR and then bone scintigraphy. With cardiac MR, what we do is that we give contrast, and by the pattern of distribution of the contrast within the myocardium, we assign a specific diagnosis in a process known as phenotyping. And what we have seen in patients with cardiac amyloidosis is that after the administration of the contrast, they do have a very specific appearance with what we call abnormal Galilean kinetics. So the blood becomes black at the same time of the myocardium. And then we see this line, this white line defined as subendocardial legal enhancement. And this has been incorporated in the recent guidelines that have been published in the European Journal, where a characteristic CMR has been defined as diffuse subendocardial or transmural LGE. Transmural is when the whole myocardium is white, as here represented on the right, coupled with abnormal Galilean kinetics. So these features are sufficient to make basically cardiac amyloidosis a very likely diagnosis. The other imaging modality which really have transformed the diagnostic pathway, especially in TTR patients, is bone scintigraphy. What we do with bone scintigraphy is that we give a bone tracer to look for any evidence of cardiac uptake. And the way we classify is very simple. So when there is a grade 1 is a mild cardiac uptake with no attenuation in the bone, grade 2, moderate cardiac uptake greater than the bone, and grade 3 when there's a strong cardiac uptake with little or no bone signal. This is basically with DPD scintigraphy, which is one of the types of bone scintigraphy. But is it that simple? So the way to basically to proceed with the classification is like when we have a grade 0, we always have to have a SPECT, which confirms the absence of uptake in the myocardium. In grade 1 is when we have mild cardiac uptake, which is inferior than the bone. Grade 2 is that when there is moderate cardiac uptake with some attenuation in the bone, but the tip is that you still can count the ribs and vertebrae, but long bones are difficult to see. And grade 3 is when there is intense cardiac uptake with mild or absent bone uptake, and the tip is unable to count the ribs or the vertebrae. But it's really that simple. So this one is a grade 2, and this one is a grade 2, but also this one is a grade 2. And also this one is a grade 2, possibly 3. So the spectrum of grade 2 can be quite wide, and sometimes it's difficult to say if it's grade 2 or 3, but actually you will see that in the diagnostic pathway, it doesn't really matter if you classify a patient as grade 2 or grade 3. And the SPECT is absolutely important. Here you would classify this patient as grade 0, but actually if you look at the SPECT, there is cardiac uptake. So this one is grade 1. And these patients, then what grade is this patient? There's so much soft tissue uptake, it's really difficult to understand the degree of cardiac uptake, but actually the SPECT confirm that is a grade 3. So how do we use then bone scintigraphy? How do we use all this grading system? If you have heart failure symptoms and a CMR echo suggestive cardiac amyloid, then you can proceed with the bone scintigraphy. And if you can classify the bone scintigraphy as grade 2 and 3, in the absence of a plasma cell dyscrasia, which means that you have a negative serum immunofixation, negative urine immunofixation, and normal free light chains, then you can confirm a diagnosis of cardiac TTR amyloidosis without the need of any biopsy. And the only extra step you need to do is TTR genotyping to confirm if it's wild type or hereditary. And this algorithm that was published as a multi-center collaboration in 2016 has absolutely transformed our non-invasive diagnostic approach in TTR amyloid. So, but then what are the current clinical applications? How do we combine all this imaging into clinical practice? As cardiologists, we have two common clinical scenarios in clinic. One is more rare, is that patients that come with a diagnosis of systemic amyloidosis, and we want to know if there's cardiac involvement. And the second one is patients with an hypertrophy phenotype, and we want to know if it's cardiac amyloidosis or something else. So in the first scenario, which is less common, so patients with a known diagnosis of systemic amyloidosis, we have two options. One is a patient with, for example, ATTR amyloid neuropathy or TTR mutation carriers. So then bone scintigraphy is probably the imaging of choice because it's extremely sensitive and specific. But also we need to bear in mind that some mutations may have a falsely negative cardiac uptake. Instead, in patients with systemic AL amyloidosis, cardiac MRI is definitely the imaging of choice because bone scintigraphy is positive in less than 40% of patients with cardiac AL amyloidosis. But what about patients with the hypertrophy phenotype? Here I would say CMR has definitely got an advantage because we'll tell you, yes, it's amyloid, not is not amyloid, but also will give you information about a wide range of differentials that do exist in the hypertrophy phenotype. Then let's have a look at some clinical example. This one is a 75-year-old gentleman with shortness of breath, echo showed a symmetric increase in LV mass, and this patient doesn't have a plasma cell dyscrasia, as confirmed by a negative serum and urine immunofixation and negative free light chains. So in these patients, the DPD is grade 2. So if you look at the algorithm, you follow the right side, and we had a clinical suspicion of cardiac amyloidosis, with a grade 2 bone scintigraphy, then we can confirm a diagnosis of cardiac ATTR amyloidosis without the need of biopsy. And the only extra step is really the TTR genotyping. This is the second patient, 70-year-old gentleman with shortness of breath and edema, and the echo showed an increase in LV mass. This patient, the DPD is probably grade 1, so only mild cardiac uptake, which is less than the bone, is quite clear in this case. And here, the CMR is absolutely typical. You follow the center part of the algorithm, so a grade 1 bone scintigraphy with a plasma cell dyscrasia. The algorithm simply states it needs specialized assessment, but now we know that a DPD grade 1 with a characteristic CMR is very likely to be cardiac AL amyloidosis. The last case, 6-year-old lady with shortness of breath. The echo again showed increase in LV mass, suspicion of cardiac amyloidosis, but the patient doesn't have an MGUS. So with negative serum and urine immunofixation and negative free light chains. And this patient has got a grade 0 DPD. And you see that on the CMR, there is lots of gap, but it's actually mid-wall, patchy, and there's no orthogonal kinetics. If you look at the algorithm with a grade 0 bone scintigraphy and no plasma cell dyscrasia, cardiac AL and ATTR amyloidosis are unlikely, so you need to review the CMR. And here the CMR confirmed features that were more in keeping with hypertrophic cardiomyopathy. So we have looked over how we combine the different imaging techniques to reach the correct diagnosis. But can we go a step further and measure the cardiac amyloid burden? So we can do that with CMR and T1 mapping. So what we do is that with one breath hold, we get one of these maps, which is a non-contrast T1 map. Then we give contrast that goes just to the extracellular space. And by repeating the T1 map after contrast, so another breath hold, we get one of these images, which is a pixel by pixel quantification of the extracellular volume. And because the amyloid sits in the extracellular space, then the extracellular volume in amyloid is a measure of the amyloid burden. And this is a clinical example of why you need to have a measure of the amyloid burden. These are two TTR patients, same increase in LV mass, same decrease of systolic and diastolic dysfunction. So you would think probably they are the same stage of disease, same degree of amyloid infiltration. But already on the non-contrast map, you see there is a difference in the T1. And when you look at the late GAD, it looks different. The patient at the bottom probably is more white, so more amyloid. But actually, the difference is striking on the extracellular volume map, where in the top patients, the extracellular volume is 39%, so probably mild degree of amyloid infiltration. Patient at the bottom, extracellular volume is 62%, so a severe degree of amyloid infiltration. So the structure and function is really not enough. You need to have information about the tissue composition. We can measure the amyloid not just in the heart, but also the liver and the spleen. This has been recently published in Cardiovascular Imaging. It's a study which uses SAP scintigraphy, which is the current reference standard for extracardiac amyloid. And here you see the extracellular volume maps, which have been taken in a cardiac MRI scans, but in more than 95% of the cardiac MRI scans, we actually image also the liver and the spleen. And you can see at the top, the spleen and liver in blue. There's no cardiac amyloid. At the bottom, they are red and white. There is a severe degree of amyloid infiltration. But then, so we can make a diagnosis. We can measure the cardiac amyloid burden. But can we track changes with treatment? So track changes over time. This is from a study of more than 150 patients with AL amyloidosis. And you can see that at 12 months, a good proportion of patients have amyloid regression. So amyloid regression is something that like 3-4 years ago, we thought it wasn't possible. So why is now, like we are now saying that 30% of the patients do have actually regression? Because what you cannot see, what you cannot measure, it actually doesn't exist. So what CMR has allowed us to do is allowed to visualize mechanisms and phenomena that before we were not able to visualize. And this is an example. At the top, you see the baseline. The patient has got typical features of cardiac amyloid with diffuse transmural leg enhancement, altered kinetics, high extracellular volume. And 12 months after, the leg gut is almost normalized and extracellular volume is nicely come down. But what about the TTR? Can we track changes in TTR? This is a very small study in 16 control compared with 16 patients with TTR amyloidosis on patisiran. So patisiran reduces the amyloid production, is an RNA interferon, and that were scanned at baseline and then 12 months after, together with a serious VADA test. So there were no differences on the structure and function as assessed by echocardiography with a wide range of deformation and non-deformation-based parameters. There was some decline in NT-proBNP and improvement in the 6-minute walking test, but these were patients with peripheral neuropathy. So the improvement in the 6-minute walking test could have just been due to the improvement in neuropathy, which is well described in patients with on patisiran. But then what happened to the amyloid load? What we typically see in these patients is relentless progression. A baseline is a patient with TTR amyloid, and at the bottom is 12 months after. And this is the patients with no treatment. And what you can see is that at the bottom, there is more red. So the amyloid load has gone up. And we typically see this in every single patient with TTR. But what happened in these patients? In patients treated with patisiran, patisiran was typically associated with a reduction in ECV with an adjusted mean difference between groups of minus 6.2%. And you can see that what happened in the overall population is an average, reduction, but actually there is proportion of patients who are stable, proportion progress, and proportion regressed. So measuring the extracellular volume really gives information about the individual response in each patient. And this is an example of one of these patients. So at the bottom of baseline, at the top is baseline, at the bottom is 12 months after. 12 months after, you see that lots of blue dots start to appear into the myocardium, which correspond to a reduction in ECV, which is more likely to be in keeping with a reduction in the amyloid deposits. So in conclusion, cardiac amyloidosis is a rapidly progressive fatal disease for which effective treatments are available. Echocardiography and blood-based markers are useful to raise the suspicion of cardiac amyloidosis, but the specificity and positive predictive value are very low. CMR with leg enhancement, DPD, and then peripheral biopsy have a crucial role in confirming the diagnosis and differentiate it from other clinical phenocopies. And it's really a combination of these three elements that will get you to the correct diagnosis. And if we want to go a step further with CMR and T1 mapping, we can measure the amyloid load, and then hopefully in the future, we will be able to prove that we can stratify treatment response. Thank you very much for the attention.
Muchas gracias, Mariana. Excelente presentación, muy completa, muy clara. Bueno, te doy el lugar, Jorge, para que lo presentes a Omar.
Bueno, gracias, Carlos. Bueno, tratando de seguir con este webinar de amiloidosis, vamos a tener la posibilidad de escucharlo a Omar AbouEzzeddine, y quien se desarrolla en el Departamento de Cardiología Nuclear de la Clínica Mayo, y vamos a tener la posibilidad de poder escuchar algunos datos con relación a consejos y dificultades en las imágenes nucleares en la amiloidosis cardíaca. Así que, Omar, cuando quieras podemos comenzar.
Thank you. Can you hear me?
Yes.
Okay, good. Well, thanks again for the invitation, and it's really a pleasure and privilege to be with you all and to share the podium with our distinguished speakers. So I'm just going to dive right in. Let's see. Here are my disclosures. So I have two learning objectives today. The first is some overlap with what Dr. Fontana had gone over, defining the role of PYP imaging in, or bone scintigraphy, I should say, in diagnostic workup of TTR cardiac amyloid. And the second is highlighting some pitfalls and perils as of PYP. So very briefly, diving in, just a reminder, cardiac amyloidosis is a toxic infiltrative cardiomyopathy. There's two types. In light chain, the origin of the protein is the bone marrow, where in a monoclonal process occurs, and you have these light chains that then invade the myocardium and cause direct myocardial necrosis and increased myocardial stiffness and heart failure. In transthyretin cardiac amyloid, however, the process relates to the liver. So these transthyretin is a ubiquitous protein. It's a transporter protein that comes from hepatocytes, normally a tetramer, that either because of genetic reasons or for age dissociates, becomes unstable, dissociates into monomers, and then these monomers then form amyloid fibrils, which themselves infiltrate the myocardial space, causing increased myocardial stiffness, heart failure, and also myocardial necrosis, similar to AL. Now we're going to just focus on TTR cardiac amyloid for the purpose of nuclear imaging. And the reason that this is important is really compared to the 80s, there's been a paradigm shift in how we think about amyloid. Back in the 80s, it was thought that screening for amyloid is only for diagnostic interest, but there was no therapy for this, and it was thought to be rare. But in the current era, we now know that TTR cardiac amyloidosis actually contributes to a significant amount of patients who have heart failure with mid-range to preserved ejection fraction and even sometimes reduced EF. And we finally now have therapy for this that is quite effective. And with this interest, there's really been an explosion in the number of studies that relate to this, to the prevalence of TTR amyloid. And you could see it ranges anywhere from 5 to 10% of non-invasive studies and around 25% on autopsy studies. When do we suspect amyloid? AL, as Marianna had nicely mentioned, is more of a systemic process involving the heart, the nerves, the kidneys. Typically, transthyretin amyloidosis involves the heart, causing diastolic dysfunction, atrial arrhythmias and such, as well as the nerves in the case of hereditary TTR, and to a lesser extent in the case of wild type or non-mutant TTR amyloid. Some clinical pearls, sometimes a picture is worth 100 words. You could see here biceps tendon rupture, spinal stenosis, atrial arrhythmias, and carpal tunnel syndrome, typically in TTR, perioral orbital purpura, and macroglossia in AL. And so after you have this clinical history of heart failure and such tips, then you start looking at the diagnostic testing, which I won't go over again, but Marianna had touched upon: echocardiography, MRI findings of restrictive filling on echo, restrictive cardiomyopathy, large atria, abnormal strain imaging, and the MRI findings that Marianna clearly went over. So historically, with clinical suspicion and supportive echocardiographic imaging or MRI imaging, we then go into the first and foremost ruling out AL amyloid, because AL amyloid is a much poorer prognosis compared to TTR. So the first thing that you need to rule out is monoclonal protein or monoclonal processes. And so if you have that present, then you really need to reach out to your hematologist for an emergent hematologic workup, which may at times include a cardiac biopsy. If you do not have monoclonal protein that is present and you're suspecting TTR, historically we have gone for cardiac biopsy, whereby on pathology you see this green, apple green birefringence, particularly when you use Congo red staining under polarized light. However, endomyocardial biopsy, as we see, has a lot of limitations. It's invasive with a risk of complications. You need access to a cath lab, which if you're in the community, you don't have access to necessarily. It's costly and very, as Marianna astutely commented, you really can't tell much about amyloid burden when you have 5 samples of cardiac biopsy. And this really is where bone scintigraphy has really revolutionized the field of diagnosis. And this is not a new idea. It actually was first described in the 80s with these technetium bone tracers that were, this technology was abandoned back then because seemingly some patients did not have positive studies. Well, in retrospect, these were light chain amyloid patients rather than TTR amyloid patients. And hence, this was looked at again in the early 2000s by Claudio Rapezzi and his group in Italy. Very small study. You no longer can get this accepted in JACC in the current era, but really a very contributory study. They looked at patients with controls, ALs and TTR, cardiac amyloid, and using the bone radiotracer DPD, at least they found that patients who had TTR amyloid had a positive study as shown here, compared with a high signal compared to the bone, and AL and controls had no myocardial uptake, at least in this study, and they could quantify it using the visual score that Marianna mentioned. So 0, no myocardial uptake, 1, less than bone, 2, equal to bone, or 3, myocardial uptake, more than bone. And really, this was the revival of nuclear cardiology. Other groups, including Matt Maurer's group in Colombia, then started quantifying this, and they found that a cutoff of heart over contralateral uptake of more than 1.5 at 3 hours, at 1 hour, or 1.3 at 3 hours, could differentiate patients with wild type or hereditary TTR from those with light chain amyloid. But caution, some of these light chain amyloid patients had some uptake that was seen. And really, it wasn't until this seminal paper that was published by Dr. Gilmore from London that really showed that the sensitivity of this is very high for PYP or DPD scintigraphy, over 99%. The specificity really was limited by those false positives that were due to uptake in AL. And so the authors concluded that in the absence of monoclonal proteins, the specificity and the positive predictive value of this study approaches 100%. And the multi-societal guidelines then really came out and said, well, if you have a positive PYP scan or bone scintigraphy, if you have typical cardiac imaging features, and if you have absence of a monoclonal protein process, then you have a diagnosis of TTR cardiac amyloid without any invasive testing. And so over the course of the last 10 years, if you want, there's really been an increase shown here in green in the number of PYP scans that we've been doing in this country. And as you would expect, a decrease in the number of positive scans. And that's just the dynamics of new imaging. But the concern arose that, are we really imaging appropriately? Are we really interpreting appropriately? And Matt Maurer and Rick Ruberg published this very, humbling piece that really said that, 1, we're concerned of inappropriate application of scintigraphy. 2, there's an increase in false positive scans that's very alarming. And 3, that providers are not adhering to the well-vetted guidance of the guidelines that were described on the last slide. And that brings me to the next point, and that is to highlight the pitfalls and perils and caution with PYP imaging. First and foremost, planar imaging is not sufficient. A planar image, as shown here, is a 2D representation of what's happening in a 3D cavity that is the chest. And so to bank on to carry on with what Marianna said, you really need SPECT imaging, and if possible, SPECT CT would be nice to really identify if the uptake is in the myocardium or in the blood pool or rib fractures or pleural effusion or breast tissue, etc. And really beware false positive. Planar imaging is no longer sufficient, and I think in the future may very well be abolished completely, because really what you need is to see the uptake in the myocardium rather than extracardiac structures as listed here: fractures, valvular or annular calcifications, nodules, and blood pool as mentioned. Keeping in mind that grade 2 uptake, as shown here on this very nice planar image, could also occur in dilated cardiomyopathy. This is a patient who we saw in clinic. Martha Grogan saw this patient who was referred to us, initiated on tafamidis for a positive study, positive planar image, negative light chains. This was thought to be TTR. Well, when we did SPECT CT imaging here, well, first, when you listened to the patient, they had this diastolic murmur that was very suggestive of severe aortic regurgitation. And indeed, on SPECT CT, this was all in the blood pool. So SPECT is a must. It prevents misdiagnosis in around 20% of cases, and others, including our group, has shown this. Matt Maurer's group recently also published this, showing that planar imaging had false positive results in up to 2/3 of patients with grade 2 scans in their institution. And so now we really recommend that SPECT imaging is necessary. Further, the other thing that was recommended is we should consider later imaging, 2 to 3 hour imaging, also to reduce the false positive rate. And so here at Mayo, we do both planar and SPECT CT, and we quantify it in both modalities as shown here. Another caution, PYP uptake, even grade 2 and even grade 3, as shown in this beautiful SPECT CT, could occur in light chain amyloid. This is a patient who unfortunately passed away in our CCU after being referred from an outside institution on tafamidis for 6 months for a presumed positive scan, but no one ever checked the light change. And this patient, unfortunately, was diagnosed too late. When Matt Maurer looked at this in their group, less than 40% of their patients had complete testing for light chain amyloid. And this is an academic institution that was pivotal in this technique. So this really tells us that there is a problem out there of appropriate use of this imaging modality. In fact, the guidelines would say if you have abnormal light chains, then it's rarely appropriate to do a PYP scan, and really you need a biopsy of the heart. Beware, we have also seen false uptake in patients with end-stage renal disease, as shown in this case. This patient had no evidence of cardiac amyloid whatsoever, and this was thought to be secondary to long-standing chronic dialysis. Ian Chang from our group also showed false positivity on SPECT CT in a patient with plaquenil. This is pathognomonic electron microscopy of a patient with plaquenil or hydroxychloroquine toxicity. Marianna alluded to this as well. False negatives can occur. There are some genetic mutations that form TTR fibrils that are a mixture of those full-length that are only full-length fibrils. And these fibers are thought not to be as problematic to the cardiomyocyte architecture, if you want. It's thought not to cause a lot of chaos in the structure of the myocardium. And that's why you normally would have a negative scan with those, it's believed to be. In wild type and other more common genetic mutations, this is not the case, and they clearly have a very positive scan. So not all TTR will light up on a PYP scan, and as I had shown earlier, not all that lights up on a PYP scan is TTR. This is a patient with, I showed, with no amyloid. This is a patient with plaquenil toxicity, positive PYP scan. This is a patient with light chain amyloid with grade 3 uptake. This is a patient who had both AL and TTR in the heart muscle on biopsy and mass spec. So, with a positive PYP scan, and this is the patient that was positive on planar image, but not on SPECT CT. So to add to the diagnostic algorithm, today in the current era, after ruling out monoclonal protein absence, then you can depend on PYP imaging for a positive, for diagnosis, a non-invasive diagnosis of transthyretin cardiac amyloid. However, caution, if a study is negative or equivocal and you are still suspicious clinically, you really have to go and do a biopsy. So really the biopsy is no longer obsolete. And to summarize, the caveats of bone scintigraphy: beware false positives such as light chain amyloid, hydroxychloroquine toxicity, blood pool or rib fractures and breast implants. Recent MI within 4 weeks also could cause a false positive scan. And beware false negatives with these full-length type B fibrils, such as those associated with these mutations, early disease or delayed imaging. And so really, if you still have a strong clinical suspicion, despite a negative PYP scan or DPT scan, a biopsy is indicated. So to summarize, after clinical suspicion is raised and in the presence of typical cardiac imaging features, you really need to get your light chains and monoclonal protein studies, as well as a PYP scan with SPECT, preferably at 2 to 3 hours to diagnose this. In the absence of monoclonal protein, the diagnosis is made, in this case, without any tissue. The endomyocardial biopsy is no longer the default, it's now the exception to the rule. Beware false positives, such as those listed here that we have gone over. Beware false negatives, such as certain hereditary variants, early disease or delayed imaging. And keep in mind that endomyocardial biopsy is not obsolete. If a PYP scan is positive and you have abnormal hematologic workup, you need a biopsy of the heart. If the PYP scan is equivocal or negative and you're still suspicious clinically, you have to get a heart biopsy. So this technique really has not replaced endomyocardial biopsy per se. So with that, I'd like to end, and we'll open it up to discussion or move on to Dr. Lyle's presentation. Thanks again for your attention.
Bueno, muchas gracias, Omar. Excelente presentación. Vamos a dar paso ahora a la última conferencia a cargo de Melissa Light. Melissa Light es staff del Departamento de Insuficiencia Cardíaca y Trasplante de la Clínica Mayo, pero en Jacksonville, en Florida. Ella está encargada del programa de amiloidosis cardíaca. Y bueno, nos va a dar una conferencia sobre la estratificación de riesgo y el manejo actual de la amiloidosis por transthyretina. Melissa, muchas gracias por tu participación.
Perfect. Well, good afternoon, everyone. And I just would like to say thank you so much for having me. And I'm excited to talk to you a little bit about risk stratification and ATTR amyloid, as well as current management. So here are my learning objectives, and I have no disclosures. And so we'll actually start with what you just saw from Dr. AbouEzzeddine, but as a reminder, we know that about 99% of transthyretin or TTR protein is produced by the liver. That four-sided tetramer is going to become unstable potentially and break apart into the amyloidogenic monomers. And that's really the rate limiting step of TTR amyloidosis. Those monomers then aggregate together and form amyloid fibrils that they can then infiltrate different tissues and organs and nerves. And so we'll come back to that rate limiting step when we talk more about the therapeutic options we have. So I'd like to briefly go over a case I had in clinic recently. I had an 82-year-old male who presented with dyspnea. His past medical history included a spontaneous biceps tendon rupture and lumbar stenosis, as well as a history of atrial fibrillation. So his transthoracic echocardiogram demonstrated, as you can see here from the parasternal long axis view and the parasternal short axis view, increased left ventricular wall thickness. And from the apical four-chamber view, you really see the increased biventricular wall thickness. And then his global average left ventricular peak systolic strain was abnormal with the apical sparing pattern that Dr. Fontana had talked to you about previously. He also did have a cardiac MRI as well that demonstrated late gadolinium enhancement in a subendocardial pattern. So very suspicious for an infiltrative process. So as part of his evaluation, he started off with lab work, and this was abnormal. It demonstrated a free light chain ratio of 3, and his serum immunofixation did show a small monoclonal IgG kappa. So he was seen by one of our hematologists and did have a bone marrow biopsy and also a fat pad biopsy, and neither were actually positive for amyloid deposits, and he was diagnosed with a monoclonal gammopathy of undetermined significance, or an MGUS. Other pertinent lab work demonstrated elevated cardiac biomarkers. In the setting of a relatively normal renal function, he had a troponin, a high sensitivity troponin of 30, and an NT-proBNP of 1900. So because of the presence of a monoclonal protein, we did proceed with an endomyocardial biopsy, as Dr. AbouEzzeddine just spoke with you about. And I love this acronym from Dr. Dan Judge, shared by Dr. Martha Grogan, that if there is an MGUS, you must go under the skin. So we proceeded with endomyocardial biopsy, and this demonstrated amyloid deposits by Congo red staining. Mass spectrometry was performed for amyloid typing and was consistent with TTR amyloid. He had genetic testing as part of our diagnostic algorithm, and this did not demonstrate an inherited mutation, so he was diagnosed with wild-type TTR amyloid, Mayo stage 1, and he was initiated on tafamidis. So I mentioned staging. So this is important to think about for risk stratification for these patients. And how long do they live? What's their life expectancy? So first off, the life expectancy of an untreated wild-type ATTR cardiac amyloid patient is still approximately 3.5 years untreated. And a hereditary ATTR cardiac amyloid patient untreated has a life expectancy of around 2.5 years. So our Mayo Clinic TTR staging system looks specifically at wild-type TTR cardiac amyloid patients, and we use cardiac biomarkers, including a troponin cutoff of troponin T of 0.05, now a high sensitivity troponin of greater than or equal to 65, or an NT-proBNP greater than 3,000. And this is stage 1, stage 2, and stage 3, with stage 3 being a patient who has biomarkers above each threshold, an NT-proBNP greater than 3,000 and a high sensitivity troponin greater than 65. The median life expectancy for someone who's stage 3 is about 20 months. So the UK National Amyloid Center came up with an additional staging system, which also incorporates hereditary patients. So looking at wild type and hereditary TTR cardiac amyloid patients, using an NT-proBNP cutoff of 3,000, but then incorporating renal function and looking at a GFR cutoff of less than or equal to 45. And so when you meet the threshold for both renal function and elevated NT-proBNP, that was also considered stage 3 with a median survival of around 24 months. So how do we manage these patients? Well, first off, in terms of general recommendation, loop diuretics remain the mainstay of therapy. And it's important to consider that you need to have a fine balance between relieving congestion, but also maintaining appropriate preload to maintain a good cardiac output in these patients who have a restrictive physiology. I prefer to utilize loop diuretics with better bioavailability, torsemide or Bumex, and then I often use an aldosterone antagonist for a synergistic effect, as well as potassium sparing. But it is important to recognize if you have a patient that continues to experience increasing need for further and further higher doses of diuretics, that is a surrogate for disease progression. So expert consensus documents and guidelines really don't recommend the use of neurohormonal antagonism, and even with patients with a reduced ejection fraction. And why is that? Well, it's because they don't typically tolerate these types of medicines, particularly beta blockers. And someone who is already relatively rate dependent with a fixed low stroke volume, they don't often tolerate the addition of high dose beta blockade. Although we do have to use beta blockers occasionally in patients for rate control with atrial fibrillation. And atrial fibrillation is quite common, as are bradyarrhythmias and other tachyarrhythmias. But in wild-type TTR, about 70% of those patients end up developing atrial fibrillation. And this is important for you to consider in your patients because anticoagulation is recommended regardless of the CHADS-2-VAS score. And also, if your patient's going to be undergoing a cardioversion, we really recommend transesophageal echocardiography preemptively and beforehand. And this is because we know that these patients have a high propensity for formation of intracardiac thrombi, really despite the use and appropriate use of anticoagulation. So in terms of TTR targeted therapies, there's been a lot of advancements in the last several years. So we really want to focus on stabilization, but then also suppression at the level of the liver. So if we think about where we're targeting therapy, so let's actually first start with that rate limiting step that I mentioned before, the disassociation of the tetramer into those amyloidogenic monomers. So we have three stabilizers, diflunisal, tafamidis, and AG10, or acoramidis. And so diflunisal and tafamidis both act by binding to the T4 binding site, preventing that disassociation of the tetramer into monomers. And then AG10 is actually going to mimic the stabilizing properties of another genetic mutation, preventing, though still, the disassociation into the monomers. So for diflunisal, this has been shown, it's a non-steroidal anti-inflammatory agent. It's been shown to be beneficial in patients with TTR polyneuropathy. However, it can also be used in cases of early cardiomyopathy, but it's important to be very cautious regarding renal function and also fluid retention, given it is an NSAID. So tafamidis is a TTR stabilizer that was seen in the ATTRACT trial to be very beneficial for this patient population. So this study was published in the New England Journal of Medicine in September of 2018, and this randomized patients to either with both hereditary and wild type cardiac ATTR amyloid to either 20 milligrams of tafamidis, 80 milligrams of tafamidis, or placebo. And what did they find? A substantial improvement and reduction in all-cause mortality. So 30% reduction in all-cause mortality when cardiac transplantation was included as a death surrogate. And then a 32% reduction in heart failure hospitalizations. Important to remember that the survival curves, as you can see here, don't really separate out until about 18 months on drug. However, this really equates to a number needed to treat of about 8 patients to prevent a death at 2.5 years, and a number needed to treat of about 4 patients to prevent 1 hospitalization at a year. And just for reference, when we think about classic neurohormonal antagonism and heart failure with reduced ejection fraction, for ACE inhibitors, the original trials, the number needed to treat was actually 77 to prevent a death at 1 year. So we know that tafamidis is going to slow the progression of the disease. It does not reverse or halt the disease, but as you can see here, it slows the decline in the 6-minute walk, as well as the decline in quality of life as assessed by the Kansas City Cardiomyopathy Questionnaire. And extended studies showed there was added benefit of the 80 milligram dose for further reduction in all-cause mortality. And that's why it's currently the recommended dose, either in the formulation of 20 milligram capsules for a total 80 milligram dose, or in a 61 milligram new formulation that's bioequivalent. So AG10 or acoramidis, as I mentioned earlier, mimics a stabilizing variant and works to decrease the disassociation of the TTR tetramer into those amyloidogenic monomers. And this is currently being evaluated in the ATTRibute trial. And the 12-month assessment actually showed that it did not reach its primary endpoint of improvement in 6-minute walk. But clearly there was improvement in the serum TTR concentration, NT-proBNP, and also quality of life. So we we know that it's stabilizing the tetramer, it may be a fact that the patient population in the ATTRibute trial is maybe not quite as sick as the patient population in ATTRACT, given increasing awareness and earlier detection of amyloid. And so hopefully, as we have continued monitoring of this patient population, we'll see it meet the endpoints in the later analysis. So now let's look back at the level of the liver. So can we cause suppression of the TTR production in general? And so these are through our silencers. And the two silencers that we have act in different ways, but their goal is to suppress the production of TTR in general. Inotersen is given as a sub-Q injection every 3 weeks, or weekly, and patisiran is given every 3 weeks as an IV infusion. And so both of these were evaluated in large clinical trials that were published in New England Journal of Medicine, the Apollo trial and the NEURO-TTR trial. And this led to their approval currently for hereditary ATTR polyneuropathy. However, the Apollo study for patisiran also had a cardiac subgroup, and this looked at patients with a left ventricular wall thickness greater than 13 millimeters without any concomitant aortic stenosis or hypertension. And this patient population actually had improvement in their left ventricular wall thickness, as well as NT-proBNP and actually strain pattern as well. So there are very exciting things in the realm of silencer trials that are coming up soon. So Apollo B looks at patients that are randomized to either patisiran or placebo, primary outcome being 6-minute walk, and then secondary outcome being cardiovascular mortality and heart failure hospitalizations. Helios B is looking at vutrisiran, which is a second-generation silencer. And the important part about this is that it's only every 3 months, so a sub-Q injection every 3 months. Helios A was studying vutrisiran in patients with polyneuropathy, and the initial results from that trial are showing improvement in the neuropathy impairment score as well as quality of life. CardioTransform is looking at the second-generation silencer, very similar to inotersen without the side effects of glomerular nephritis and thrombocytopenia. And the important part about 2 of these trials are that they do include patients with, particularly Helios B and CardioTransform, patients who are continued on their TTR stabilizer therapy, so tafamidis. So we'll have some idea about the role of concomitant use of stabilization and silencing. So as a comment about degradation and extraction. So previously we were using a lot of doxycycline and TUDCA that was thought to be synergistic with the doxycycline to disrupt the TTR fibrils and remove them. But later studies have shown that actually this is not that beneficial for our patients and associated with a lot of side effects, GI toxicity and photosensitivity. So we no longer recommend these medications. However, there have also been a lot of upcoming trials on degradation and extraction. There were several phase 1 studies that looked at monoclonal antibodies that target the TTR aggregate to focus on extraction from the myocardium. And now they've moved into phase 2 trials. So very exciting in the area of TTR targeted therapies. And so CRISPR therapy has been also a hot topic, and this is in vivo gene editing, looking at modifying target DNA. And so this phase 1 study by Dr. Gilmore and colleagues, including Dr. Fontana, was published in the New England Journal of Medicine in August of 2021, looking at 6 patients with hereditary TTR polyneuropathy who received the CRISPR therapy at differing doses. And the higher dose was associated with an 87% reduction in TTR at 28 days. So not quite ready for prime time, but very exciting. And so I want to end talking about cardiac transplantation and advanced therapies. So a lot of the targeted therapies, the specific TTR targeted therapies I've mentioned are for New York Heart Association class 1 to 3 patients. But what about our New York Heart Association class 4 patients, our end-stage heart failure? What can we do for them? Well, although technically feasible, left ventricular assist device implantation is often contraindicated due to the small ventricular size as well as the biventricular nature of the amyloid cardiomyopathy in general. There have been instances of the use of BiVADs or total artificial heart for bridging purposes to transplantation, but really transplantation is our main advanced therapy for these patients in a select group of this population. And it's important to mention that actually cardiac transplantation was originally thought to be contraindicated, and this was because of concern for recurrence of the amyloid deposits in the transplanted allograft. But this was based on historical data in the 1980s and 1990s, typically with AL patients, and we've had a lot of advancements in chemotherapy since then. So modern era data for cardiac transplantation and amyloidosis actually show that the 1-year survival outcomes are very similar to those patients who have cardiac amyloid and were transplanted compared to those patients who were transplanted for a non-amyloid cardiac reason. And also the outcomes are very similar between TTR and also AL. But an important thing to think about is our TTR patients, both wild type and hereditary. So they undergo a heart transplantation, but we've actually seen that there can be progression of their extracardiac manifestations post-transplant. The Columbia group just published in Journal of Heart and Lung Transplantation their analysis on the extracardiac manifestations in both hereditary and wild type patients. So how do we treat those patients, and how do we utilize all of our TTR targeted therapy in that population? And there are ongoing studies looking into this and lots to still be learned. So that was a quick overview on the updates for TTR targeted therapies, and it's very exciting with lots of upcoming trials and big things to come. So with that, I think we'll take questions and discussion.
Excelente conferencia, Melissa, muchas gracias. Jorge.
Bueno, en realidad, después de estas 3 disertaciones excelentes, me imagino que debe haber un montón de preguntas, pero vamos a ir, en función del tiempo, a comprometer a los panelistas que tienen altísimo nivel. Me gustaría presentar a Juan Erriest. Juan es el jefe de Medicina Nuclear del Hospital Italiano de La Plata. Y bueno, Juan, si tenés alguna pregunta, por favor.
Bueno, gracias, Jorge. Bueno, primero quiero agradecer a Carlos la invitación y quiero felicitar a Marianna, a Omar y a Melissa. La verdad que muy lindas las presentaciones. Y con respecto a lo que es el algoritmo diagnóstico, para cualquiera el que quiera contestarlo, los que más hablaron fueron Omar y Marianna de este tema. Si uno tiene la sospecha clínica, tiene un eco con datos patognomónicos de amiloidosis cardíaca, y tuviese que hacer un test, primero, ¿cuál elegiría? Si un centellograma, si definir si tiene o no tiene presencia de cadenas livianas, eventualmente los dos. En esto hay algo de controversia en la literatura, de si hay que hacer los dos al mismo tiempo, primero uno o el otro. Y en función de las presentaciones me gustaría saber en el algoritmo diagnóstico después qué lugar ocuparía la resonancia nuclear magnética, en qué casos la haríamos, y en todo caso, en qué casos terminarían realizando una biopsia endomyocardial.
Marianna, do you want me to take the first part of that question? And then maybe, oh, you're on mute. You're on mute.
Yes, especially because I didn't understand the question, so you can tell me. Like,
sure. Yeah, the first part of the question, if I understood correctly, thank you for that question, is where does if you have someone with classic history and echocardiographic findings, what do you order first, the light chains or the PYP scan? Or, you know, if you had to choose one, and this was an exam, I would say the light chains because of how emergent that diagnosis is and how poor the survival is with every day of untreated light chain amyloid. So you really have to rule out light chain amyloidosis as an emergency. So that's more of the academic answer. Clinically, I would say, and a lot of American centers, and Marianna, I'd be curious to know what you guys are doing in Europe, but a lot of the American centers order both at the same time as a part of an order set, because you really can't interpret a PYP scan without light chains. As I've shown, there have been cases of both AL and TTR. There have been cases of only AL. So really, I think both should be obtained at the same time, even though the algorithm may say rule out monoclonal protein first. I think we're just trying to emphasize that it's extremely important to do that before you start doing PYP scans, especially if you're going to refer a patient out to a nuclear center for a PYP scan. So really, I think both at the same time, if you have to choose one, I would say the monoclonal proteins. As far as where does MRI come in, here at Mayo, we're a very echo-centric space. We do MRI, but I would love to hear Marianna's input. They're very MRI heavy, and she's been doing a lot of exciting research here. So Marianna, where does MRI fit into your algorithm for these patients?
Yeah, so I agree with everything you said in the importance also to link the bone scintigraphy with the monoclonal protein assessment, which is sometimes skipped, especially by cardiologists, because they feel, oh, it's a grade 2, the patient is 75, I know the patient has got TTR, and actually we can get it heavily wrong if you do that. I think CMR is quite important in the settings of the hypertrophy phenotype, in the sense if you have an hypertrophy phenotype and there are some features of AL, but actually could also be other things, MRI is quite useful because it tells you, yes, is amyloid or not, and if it's not, it tells you which one is the differential. So, and I think it's quite difficult sometimes to have amyloid as the only differential in the hypertrophy phenotype, because often is, oh, okay, patient has got kidney dysfunction. So, and especially in condition where the post-load is, the afterload is increased, then the function structure changes on echo become very, very similar to amyloid. So aortic stenosis, severe hypertension, or end-stage kidney failure, what we find is extremely difficult to distinguish on echo structure and function which of these different things is, and where CMR is definitely useful. But if you, for example, have an hypertrophy phenotype in the absence of a plasma cell dyscrasia, then you can just go directly for a DPD, because clearly your main suspicion is actually TTR. So, but if your main suspicion is AL, then CMR is actually the test that you should choose, because, as I said, bone scintigraphy doesn't really have a good sensitivity. And but actually, it's the combination of the two that tells you what it is, because if you have a grade 0 bone scintigraphy and a characteristic CMR, 98% is going to be AL, and then you need to have peripheral biopsy. So, in a way, once you have the two tests and the plasma cell dyscrasia, you're pretty sure of what it is, and then you can go specifically for peripheral biopsy or a cardiac biopsy. And the reason for us to do most frequently a cardiac biopsy is a grade 2 or 3 bone scintigraphy and a plasma cell dyscrasia, because in that circumstance, the only way to know the amyloid type is actually a cardiac biopsy. So that's, I think, for us almost the only one of the very few indications. Definitely the most common one, yeah, for a cardiac biopsy.
Bueno, seguimos con el próximo experto local, el doctor Pérez de Arenaza. Diego es un jefe de imágenes cardiovasculares del Hospital Italiano de Buenos Aires y un referente en Argentina en resonancia cardíaca. Diego, te escuchamos.
Felicitaciones, Carlos, por la iniciativa, felicitaciones por todas las presentaciones. Una pregunta para Marianna Fontana. En la amiloidosis, el amiloide se deposita en lo basal sobre todo, y hay una preservación cuando nos vamos hacia lo apical, del gradiente vasoapical. ¿Cómo medimos cuando cuantificamos el SB? ¿Dónde lo medimos? ¿A nivel de un eje corto basal o utilizamos un 4 cámaras? ¿Cómo se mide?
So first, I'm very proud to say that I understood the question. Secondly, this is a very, very good question, because the distribution of amyloid follows typically exactly the distribution you mentioned. I think it depends a bit. So my approach is very practical and simple. The most robust way to do that is in the 4-chamber to draw a region of interest in the basal to mid settle. So 4-chamber just covers 2 segments and everything. And there are a few reasons why to do that, because the septum in MR, usually you don't have artifacts, you've got the best signal-to-noise ratio and everything. And also, when you measure that, even when you track changes over time, you are always in the same place because you plan the 4-chamber out of 3 points. So if you go and measure that, even when you track changes over time, you're always at the same value. And the vast majority of the published study have done that. So all the values, all the cutoff and everything that you find actually refer to that way of testing. So theoretically, when you do whole art, you've got some advantages, but especially because we like to say it's a whole art quantification. But actually, when you go to the apex, you've got problem partial voluming, basal infralateral wall, you've got problems with artifacts and everything. So from a diagnostic point of view, prognostic stratification, but also tracking changes over time, I think one single region of interest within the septum is the easiest approach for clinical practice.
Gracias. Muchas gracias.
Jorge.
Muy bien, bueno, seguimos con las preguntas y lo tenemos a Juan Pablo Costabel. Juan Pablo es jefe de la unidad coronaria y encargado de miocardiopatía del Instituto Cardiovascular de Buenos Aires. Así que Juan Pablo, si querés tu pregunta.
Gracias por la invitación y felicitaciones por las presentaciones que estuvieron fantásticas. Mi pregunta iba, cuando hablamos de tratamiento en transtirretina, específicamente, y digamos, hoy tenemos la información para utilizar tafamidis y había algunas preguntas en relación a eso. ¿Cómo ven el futuro del tratamiento? Si el futuro del tratamiento puede incluir tratamientos combinados o no. Creo que la mayoría de los trabajos randomizados que hoy están con los silenciadores son trabajos que la mayoría no permite la utilización de tafamidis. Entonces, a lo mejor esta respuesta no la vamos a tener, pero en un futuro, que a lo mejor es un futuro de 2 o 3 años, ¿cómo se lo imaginan?
Yeah, so I think that that's a fantastic question. And you're right, we really don't have the data. So we don't have the data currently to know about combination therapy. But that's where, as you mentioned, in a couple of years, hopefully as we see the results, particularly from the HELIOS-B study and also CardioTransform, they do have patients that have been continued on their stabilization therapy with tafamidis. So we should be able to see recommendations further on the combination therapy with silencers and also stabilizers. And then in terms of kind of what's the future, I think that the monoclonal antibodies for degradation and extraction, as they kind of move forward to phase 2 trials and phase 3 trials, I think that's a very exciting area for Ttr targeted therapies.
Perfecto, bueno, seguimos con Alejandro Quiroga. Alejandro es el encargado de miocardiopatía, de amiloidosis cardíaca en la Fundación Favaloro en Buenos Aires. Alejandro.
Muchas gracias a todos por la participación, felicitaciones por las charlas. Mi pregunta para cualquiera de los 3 expertos en realidad sería, ¿cómo hacen o cómo harían más bien ellos el manejo de los pacientes intermedios, aquellos pacientes que por ahí tienen una MCAS, una gamopatía de origen incierto, y captación en el estudio de centellograma o SPECT, viendo que en nuestro medio no hay disponibilidad de espectrometría de masa, si confiarían en la inmunohistoquímica o cómo harían el manejo de ese paciente no contando con la espectrometría de masa?
If it is for me, I need a bit of help with English translation for this question.
So basically, it points to what would any of you do with patients who have an MGUS, an abnormal free light chains, but they do have some positive PYP scan. But in our medium, we do find that it gets tricky because we do not have mass spectrometry available. So we often have to rely with immunohistochemistry, which is operator dependent. So how would you manage this set of patients?
So at the NEC, I think a bit differently from the Mayo Clinic, we have relied a lot for many, many years on immunohistochemistry. So with immunohistochemistry, you can confidently usually type TTR. The biggest problem AL, in the sense we find 20–30% of patients with AL amyloid on the biopsy, they do have non-immunospecific staining. And but in the past, so when we didn't have mass spec, patients with systemic AL amyloidosis, MGUS, and non-immunospecific staining, and of course a negative DPD or a grade 1 DPD would have been classified as systemic AL. I think the grade of the DPD then is quite important because but again, the sensitivity and specificity of the TTR antibody is much higher. So if the TTR antibodies are negative and you still find non-immunospecific staining with kappa, anti-kappa, anti-lambda antibody, the most likely scenario is still AL. So it kind of, we do a full panel of antibodies, and then by the combination of the results in the different ones, then you can really stratify the probability. Of course, now when we have that scenario, we would go for mass spec, but I think you can really diagnose the vast majority of patients with immunohistochemistry. And this is what we've done for 15 years, basically. Yeah.
I fully agree with Marianna's comments. The only thing that I would add to that is I think there is a role for fat just for your confidence too. I mean, a fat aspirate would be positive. I would say, if you're leaning towards AL, I think it's 80% if you want sensitive. In contrast, TTR is more in the 20% range. There is some data that I think is an abstract form. I'm not sure the paper's been published, but that 80% sensitivity or confidence could be increased to 90+% based on the difference between the kappa and lambda light chains. I think that was an ISA abstract a couple of years ago from our hematology group. But again, but I fully concur with Marianna. Immunohistochemistry is, 70–80% of the time your answer should be there. And for those cases that don't quite fit, and if you don't have access to mass spec, then more information would increase your confidence if you want in such as fat aspirate or urinary involvement, urinary monoclonal proteins, and things like this. So just get the full picture.
And then I think, as Omar had highlighted in his talk, once you have an abnormal, an MGUS or a monoclonal protein, working really closely with your hematology colleagues too, because they can help offer some advice as well.
Yeah.
Me gustaría hacer una pregunta que es un tema que no se tocó. Marianna, Omar y Melissa, ¿están utilizando a los pacientes valorados para TAVI, reemplazo valvular aórtico, donde la prevalencia a veces de amiloidosis es alta, la utilización del cálculo del volumen extracelular por tomografía para tener una valoración un poco no solo del pronóstico, sino para proseguir en un reemplazo valvular?
So, if I understood well, is the ECV measured with CT in the settings of patients who's going to be scheduled for TAVI? I think that's quite useful because one of the practical problems is that you're never going to do in all the patients and everything a bone scintigraphy. So if you have a way to stratify the probability, then to decide which patient to go to bone scintigraphy is very useful. And basically, you would do a CT anyway. So adding that extra acquisition, which is actually a couple of minutes, it doesn't change the protocol, doesn't change very much apart from a few extra minutes of acquisition. So I think it will actually be very useful because if you have a very low extracellular volume, the probability of cardiac amyloidosis is actually very low. So I think I know quite a few centers with high volume TAVI which have implemented this approach in the clinical practice to see really what is the positive and negative predictive value, because even if you can get a good negative predictive value, at least you know the group of the patients who shouldn't go a bone scintigraphy, and it could reduce the amount of investigations done, because I don't think it is practical everywhere to do bone scintigraphy in all patients undergoing TAVI. At least it doesn't happen everywhere. Yeah.
Perfecto, ya para terminar, te doy la palabra, Jorge, si querés hacer una pregunta y que cierres vos el webinar.
Realmente el webinar fue espléndido, sinceramente me encantó, quedaron un montón de preguntas planteadas en el chat y creo que una es interesante y me gustaría preguntárselas porque se habló de biopsia y teniendo en cuenta de la rápida y excelente evolución de las imágenes en este último tiempo para tanto diagnóstico como la estandarizar el diagnóstico a través de las diferentes formas de screening. En su experiencia, ¿cuántas biopsias endomiocárdicas hacen por o resonancias o centellos dudosas? Digo porque se habla mucho, pero en realidad parecería que se usa poco, ¿no? La biopsia endomiocárdica.
Yeah, I have a concern that we've moved, we used to do a lot of them, and then PYP came, or scintigraphy came, DPD, and we moved away from them. And I worry that, and we've had these discussions, you know, with our colleagues, that we really moved away from biopsies. I think we need to get back and do a bit more of them.
I agree. Yeah.
Because we're starting to see, for example, cases that you will see uptake. For example, the patients with end-stage renal disease, patients who have been exposed to plaquenil, patients who have hemochromatosis. I don't know what hemochromatosis would look like on a PYP scan. I just saw a patient like that today, and in the back of my mind, I was like, oh, should I do a biopsy or not? I didn't do one ultimately, but because he had other things like carpal tunnel and spinal stenosis and yada. But I do think that we need to start moving back in these equivocal cases and do more. Marianna, sorry.
I completely agree. Every Tuesday at the MDT, I'm advocating more and more biopsies in every patient where things don't fit. In the sense, even if you have got 5 things and one doesn't fit, we need to go for endomyocardial biopsy. Especially if you think that the treatment we're going to prescribe is like, how much? 250K per year. We need to be absolutely certain of the correct diagnosis. And whilst we manage to move away from biopsies, if there is even one doubt, we need to go for a cardiac biopsy. I couldn't agree more. And actually, Omar, if you want to write to all my colleagues at the NSC, I would appreciate your email stating on the importance of biopsies, because I mean, I'm an imaging person, but I do believe that anything that doesn't quite fit need to have an endomyocardial biopsy. Yeah.
Absolutely.
And I guess the only thing that I can add to it, Omar really highlighted it well, like all of the false positives, but we see them. So in the last month, I've had a hydroxychloroquine toxicity patient with a positive PYP, and I had an AL patient. So both went for biopsy and completely dramatically changed their course. And also there are risks. Of course, it's an invasive procedure, but especially with the use with echo guidance in addition to fluoroscopy, we can safely do it. So there's no real reason not to do it if it's indicated. I couldn't agree more too.
Bueno, me parece, Jorge, que vamos a cerrar acá. Quiero agradecer a Marianna, a Melissa y a Omar por este excelente webinar. Bueno, y obviamente a todos los expertos locales, a Diego, a Juan Pablo, a Alejandro y a Juan. Bueno, espero verlos a todos pronto en algún congreso presencial. Saludos a todos.
Muchas gracias.
Muchas gracias.
Gracias.
Thank you so much for the invitation.
Thank you so much.
Thank you.
Bye.
Gracias.
Thank you.